Good evening, guys. This is the next lecture for lung infections, where we stopped last time at patterns of tuberculosis. All right, we stopped here. Previously, we read about four different type of pneumonias: bronchopneumonia, round pneumonia, scattered lobar pneumonias, and other different type of pneumonias, which appears as consolidation. The concept of twin bud air bronchogram and twin bud appearances. Tuberculosis, known as TB, it's one of the widely spread infections throughout the body. But today we will just see how pulmonary manifestations do occur whenever there is tuberculosis. There are various ways, various stages, various types, various presentations, how tuberculosis can look like, and how does it appear on imaging. So going its location, it can be anywhere in the lung in children, whereas it has a predilection for upper or lower zone in adults. So depending upon the features in upper or lower zones, we have to differentiate whether it's tuberculosis or not. In children, it can appear anywhere. Post-primary infections have a strong predilection for the upper zone. What is post-primary infection? Primary tuberculosis is the one which is like treatment naive patient without any treatment first exposure to tuberculosis, and post primary infections are the one in is the one in which patient has been treated for tuberculosis previously, and there's reactivation, the disease has relapsed to come again. In those cases, the upper zones are more involved in such type of infections in various type of imaging findings, mostly cavity lesions. Millary tuberculosis that has a Millary pattern is evenly distributed throughout both lungs. It has a very peculiar pattern, Millary tuberculosis. Millary metastases cannot be differentiated from Millary tuberculosis until unless there's a history. So we have these three different radiographic features: primary tuberculosis, post-primary TB, which is like reactivation TB or recurrence of tuberculosis, and Miliary pulmonary tuberculosis. First of all, primary tuberculosis, it has patchy areas of consolidation or even lobar consolidation. Lower lobe is more effective if there's that type of lobar consolidation. That means one lobe is involved. Cavitation is uncommon in primary TB. This is one of the main areas where you should concentrate, that cavitation is uncommon. That means not very common, very rarely. But in post-primary TB, means secondary TB or there's reactivation of tuberculosis, cavitation is very common. In most cases, the infection becomes localized, occasionating granuloma, forms a tuberculoma, which we call, and eventually calcify. This is called as a Gohon lesion. In tuberculosis, whenever the Gohon lesion heals, it calcifies, called fibrosis or some mass-like appearance, is retraction, volume loss, and we can see clear cut that this is healed tuberculosis or healed Gohon lesion. Now, in cases of consolidation, this is a frontal chest radiograph. If we can see a consolidation in the right middle lobe, and hyaluronephritenopathy could be like this bulky appearance of the hyla. This can be appearance of TB. Even in some patients, only nodes are present, like sarcoidosis. We had a detailed discussion about sarcoidosis and stages from where nodes started and in pulmonary fibrosis, and nodes eventually disappear. TB has nodes which are centrally necrotic, they don't calcify. Um, in active TB, old TB nodes, they do calcify and they have a central calcification. Whether whereas the nodes in sarcoidosis, they have eggshell calcification. That's the difference between the calcification of two different type of granulomatous nodes. TB can appear as a consolidation here. We can see there's obscured silting a diaphragm here with lower pneumonia type, but this is very difficult to say this is tuberculosis. It can be bacterial infection as well. You should have a CT before labeling it TB. This is a CT of a different patient, contrast way, sorry, without contrast, where we have this central necrotic subcarinal node, mass-like appearance, consolidation in the left lobe with central areas of cavitation necrosis in the left lobe as well, and collapse, some lingular collapse is also seen. So TB has such appearances in children. Tuberculomas, whenever there's like healing thing going on, these nodules can appear as tuberculomas. They are more in the upper lobe. We can see there's increased density overlapping at the site of clavicle on the right side. So the more striking thing in children is ipsilateral hyaluronic lymphadenopathy. I've seen patients with supraclavicular lymphadenopathy as well. So unilateral lymphadenopathy is a hallmark of tuberculosis in children, and it's seen in more than 90% of the cases. But in adults, the TB, the tuberculosis solitary as nodes is not very common. Pleural effusions are frequent in adults. If there's just pleural effusion, no other features are seen, go for a pleural tab. It may show features of tuberculosis. So pleural effusion can be one of the presentations. So still now we have seen three, four things. Number one is lobar consolidation can be one of the presentations in adults. In children, it can be anywhere in the lungs, more in the lower and upper lobes, nodes which are centrally necrotic, and they can be ipsilateral nodes, a chain of nodes in children, pleural effusion, and then ganglions, which are like tuberculomas, and they eventually calcify. Calcification of the nodes is seen in 35% of cases where calcified node and a ganglion are present. The complex or the combination is known as Ranke's complex. In healed tuberculosis, when both the pulmonary ligand, which is within the lung, and the nodes, they both calcify together and they have similar appearance. You can see from density. That is called Ranke's complex. Like this is a calcified ligand with central more areas of calcification. So you see double density sign is there. So well-defined borders, no, this is not suggestive of malignancy. Calcified areas, this patient must have calcified nodes as well. They are tuberculomas. When calcified nodes are also seen in the hilar region, that is called as Ranke's complex. So you can see a soft tissue layer with dense calcification internally, centrally, and it's very well defined. You can draw out all the borders like with a pencil. Okay, this is appearance on CT for centrally necrotic, means low density nodes in the mediastinum only. So these are present at multiple stations of prevascular, left anterior, right anterior mediastinal, paratracheal, pretracheal recesses. That's a pleural effusion, how it can look like. They will be enhancing a pleural peel, uh, which is uniformly thickened pleura here. You can see the pleura is enhancing and thickening. One thing you need to remember is this: whenever a clinician orders a HRCT for TB, please do not go for it. Go for a CT with contrast, because you won't be able to see enhancement patterns of the nodes, the mass itself, and pleural effusion. There's a very much misconception among Asian countries. I've seen a lot of people ordering HRCT. They think high resolution CT chest gives a better resolution. That doesn't mean better resolution of all the diseases. That gives lung window resolution better only, which is for interstitial lung diseases. And HRCT recon can be applied to a CT with contrast, on a CT with contrast. So go for a CT with contrast, IV contrast. not the oral one. CT with IV contrast is superior to HRCT when going for pulmonary infections. We can reformat them with HRCT recon rather than going for an HRCT, which is like without contrast, and you can miss so many things. Okay, then how does the post-primary tuberculosis look like? It is also known as reactivation TB or secondary TB, which occurs years later, frequently in setting of a decreased immune status. So this is not very uncommon. Frequently, we do see reactivation TB or secondary TB. Patients, those who leave medicine in between or have very poor performance status or immune status, the disease can come back. When it comes back, it is hilarious on imaging. In majority of the cases, either the TB will develop in posterior segment of the upper lobe or superior segment of the lower lobe. So that will be around the fissures somewhere in the upper lobe or the lower lobe. If it's lower lobe, it will be in superior segment. So it will be more towards the upper side of the lung, and typical appearance will be patchy consolidation, poorly defined linear nodular opacities. In 40% of the cases, we do see cavitations. Endobronchial spread is common finding, and that will give you a nodules and branching lesions, which is called as drain bud appearance, which we have seen already in our previous lectures. So there will be 2 to 4 millimeter nodules along the bronchial walls. This is left upper lobe cavitary lesion. If you see, there's a halo in the center of the lesion, and the peripheral we have walls. So this can be this small, and this can be very, very large, occupying the whole lobe as well. So this is a big cavitary lesion. We can see cavitation, volume loss, and thick walls of the cavity in the left upper lobe. And on the right side, you can see these tree and bud nodularity, small scattered nodules. So this is typical of reactivation tuberculosis. We can see necrotic nodes as well. Okay, this is a typical appearance of treated tuberculosis with possible reactivation on chest X-ray. We can see inhomogeneous opacification of the right upper lobe with nodular branching opacities and air bronchograms, thickening along these areas with the fibrosis and volume loss. So this is typical of treated tuberculosis or previous granulomatous change. Another example of reactivation with thick wall cavitary changes. This halo is cavitation. This one. So they can be multiple clumped together. They can be a solitary lesion. We can see nodes in the hilar, subcarinal recess, and there are pleural effusions as well. Whenever you see a cavitary lesion in the upper lobe with a history of previous TB, go for reactivation TB. Reactivation TB, one word will cover most of the things in report. So there was this treated TB, Gohon lesion with calcification. Now the calcification is gone, and there is interval development of um, cavitation within the center of the lesion, which represents that disease is coming back and it's reactivating. Sometimes we just see these nodular areas in the upper lobe with a fibrosis and some nodular opacities. These can also represent um, reactivation TB. Okay, whenever there's cavitation, there's no second thought. It can be bilateral. Here we can't see, this is soft tissue window, that's lung window. You can see enhancing walls of this cavitary change in the upper lobe with scattered areas of airspace opacifications. They're more in the upper lobe. They're bounded by fissure. In the superior segment of the posterior lobe can also be the superior segment of the lower lobe. It can also be present. Otherwise, upper lobes are more uh, involved. On the right side, we can also see this lesion with central area of cavitation. These nodular areas will also cavitate at some point in time. Again, a cavitary lesion with the possible bronchial wall thickening here, and a nodular area along the fibrosis on the contralateral side. This is also reactivation TB in terms of old healed TB changes with volume loss, and we can see two areas of cavitation. This one will come from above till down and then down and down. This one, this one. These are this is one area of cavitation, and another one there's this one. Superiorly there is cavitation, and inferiorly there are areas of nodular changes with green bud appearance. Okay, endobronchial spread is more than cavitation in this patient. We can see tree and bud appearances more peripherally. These fibrotic changes are of healed TB, old one, and these are areas of nodular appearance as well. So there's tree and bud appearance more, um, which is sparing the pleural surfaces. So this is again example to show how a tree in bud appearance look like. That's a tree, and in the buds there are nodular small changes. Again, just to show how tree in bud appearance looks like. Whenever there's only tree in bud appearance, it can also be a reactivation TB, given the history, weight loss, fever, cough, hemoptysis. Again, tree in bud appearance. Okay, here we have endobronchial spread only in this portion. These fluffy nodules can be disease, cannot be disease, but this area of green bud nodularity remains suspicious just as long as though appear very clear. But this is a case of reactivation tuberculosis. Miliary pulmonary tuberculosis. This is hematogenous spread. So whenever there is a hematogenous spread, there will be no control. It will be diffused everywhere in the lungs. So it's like uncontrolled tuberculosis infection, and it can be seen both in primary and post-primary tuberculosis. Miliary TB has a little bit different etiology. We will be seeing 1 to 3 nodules. They're very small, very grainy nodular appearance, more smaller than tree and bud, and they're uniform in size. So, and there will be no calcification. That's how we differentiate between silicosis and miliary tuberculosis. Not a very good X-ray, but that shows some nodularity, discrete, small, divine. Okay, CT. That is the modality of choice. So we can see whole lung parenchyma is full of multiple small nodules. Nodules are smaller than those which are seen in tree bud, which was 2 to 4 millimeter in size, and these are 1 to 3 millimeter approximately. And there's diffuse involvement of both lung parenchyma. Yeah, in this X-ray is more evident. You can see grainy appearance of both lungs throughout without any normal parenchyma in between. A little bit more clear picture of miliary tuberculosis with diffuse involvement of both lung fields by grainy nodules. I think there's some effusion as well because I can see the um, CP angle. Um, Let me make it a bit more clear to you. Okay, this one. Multiple diffuse small nodular areas throughout the lung parenchymal fields. That's more peculiar picture of pulmonary tuberculosis, Millary pulmonary tuberculosis. So this is pre-treatment, and that's post-treatment scan of the same patient, which is showing interval reduction in size and number of the Millary nodules. So from pulmonary calcification, differential diagnosis can change. If there's localized, it can be tuberculosis. If other differentials are histoplasmosis, coccidomycosis, and blastomycosis. These three are fungal infection whenever there is a localized pulmonary calcification. So if there is single nodule present and we have calcification in it, that can be hematoma, lung cancer, the very less likely, if it is engulfing a granuloma and eccentric calcification, calcified metastases. And primary squamous or papillary adenocarcinoma. So this thing is important in a way that whenever you're seeing a small nodule which is less than 3 centimeter, if it is more than 3 centimeter, then it will become a mass in lung terminology. Less than 3 centimeter, if you see single nodule which is calcified anywhere in the lung, think of hematoma first. How will you differentiate hematoma? Will be having more fat component in it as well. So that is a benign condition, and you will be sure about it that there's calcification, fat, and some soft tissue thing. That is hematoma. Lung cancer will be having a history. A patient may be asymptomatic in hematoma. In lung cancer, a patient will be having a typical history of it. Calcified metastases. If patient has some history of malignancy already, then calcified metastases can occur. Osteosarcoma, sarcomas are known to give solitary calcified metastases. That's why we do a non-contrast CT to differentiate between enhancing nodule and a calcified nodule. Chondrosarcoma, mucinous tumors anywhere, colon or breast, and papillary carcinoma of thyroid. Thyroid has very bad metastases. They're really solitary. They give diffuse metastases in both the lungs. But solitary met can be there, so calcified. So if it is biopsiable, one should go for biopsy, given the history of malignancy, to prove whether it is a solitary met or not. Because legometastatic disease has different options for treatment. Whenever there are multiple metastatic lesions, then the options change. Okay, if the patient has multiple or diffuse calcification in the lungs, then infections like heel, Millary tuberculosis, histoplasmosis, varicella infection, that is very common, and there will be absence of nodes in such patients. Chronic pulmonary venous hypertension, especially mitral stenosis, they have diffuse multiple calcification. Silicosis calcifications are more like Millary tuberculosis pattern spread. Metastases, as I discussed before, they can be multiple. Alveolar microlithiasis, that will more smaller nodules, approximately 1 millimeter each. Metastasis due to hypercalcemia, melanoma, or other hyperthyroid conditions, and lymphoma following radiotherapy. A lymphoma after radiotherapy calcify as mass-like appearance, not nodular. Okay, interstitial ossification. They can be disseminated pulmonary ossification. You might have heard of hypertrophic pulmonary osteoarthropathy. That is a condition where these interstitial ossifications can occur, and they can be idiopathic without any reason as well. Okay, so just to summarize tuberculosis, we have seen three patterns of tuberculosis, in which there will be primary tuberculosis, consolidation, nodes, effusion, or proper mass-like appearance. Second, post-primary TB, cavitation is a hallmark. If there's cavitation, go for it. Dream bud, go for pulmonary TB, given the history of previous TB. In miliary tuberculosis, there will be miliary pattern spread in both primary and reactivation. The main thing you need to differentiate it between various infections and metastases, which may or may not calcify. History obviously is important before reporting. Abscesses, they have different etiology. The clinical picture is more septic. Patient will be having fever. Location, radiographic vision differentials we're going to see. Okay, primary abscess is develop is one which develops as a result of primary lung infection. Whenever there was a lung infection like consolidation, bacterial, viral, or any other infection, abscess can occur. Most commonly it arises from aspiration, necrotizing pneumonia, or chronic pneumonias like TB. TB can get, result in an abscess formation. Very rarely though, but streptococcus and klebsiella, hospital-acquired infections, where patients are admitted in the hospitals for long terms, go on ventilators, they are more prone to abscesses. And immunocompromised patients, like patients which are cancerous patients, diabetic patients, HIV patients. They have Candida albicans, Legionella pneumophila. These abscesses don't go so easily. It's very difficult to treat them. They remain there for weeks and weeks. And secondary, which develop because of any further condition, like if there's bronchial obstruction, bronchial carcinoma, or inhaled foreign body that becomes like infective. Post radiation, in cases of carcinoma, patient undergoes radiotherapy, and they are very common to have abscess formation after that. They are very difficult to treat as well, because you have carcinoma and then you have radiotherapy, because you need to treat that. And superadded abscess formation is hilarious. Hematogenous spread of infection, like bacteria endocarditis is there. There will be spread of infection through the bloodstream into the lungs and intrauterine devices. If there are they are infected, there will be a spread of infection through the bloodstream. And direct extension from mediastinum to subphrenic. If you remember, I had a lecture of neck spaces, from where there was a danger space, from where the infection can travel down from above to down, from the posterior nasopharyngeal area to down the mediastinum. So that can be one route, direct extension from the neck. Second thing is anteriorly from the mediastinum superior to like thyroid area to below thymus and mediastinum extension. And subphrenic, that means below the diaphragm from abdominal cavity, the infection can come up and form abscess within the lung. So abscesses can be chronic and be acute. Acute is if they're less than 6 weeks, fever, cough, shortness of breath, and if they're peripheral, like touching the pleura, the location is like that, it will cause a pleuritic pain, and that is very, very bad. Chronic are the ones which have more than 6 weeks of appearance, and they may include weight loss in addition to these constitutional symptoms. Weight loss is a bad thing. One must think of chronic non-resolving infection or abscess, which may be a tumor. They're usually on the superior segment of the right lower lobe, and classic appearance of the abscess will be air fluid level. So whenever there's an air fluid level within a pulmonary lesion, you have to look for whether it is intrapulmonary or extrapulmonary. If it is intrapulmonary, abscess is the first possible differential. Any lesion with air fluid level within the lung, abscess is the first thing you should think of. Then they will be round in shape, similar to both frontal and lateral projections. So whenever we do a lateral film, X-ray or frontal, their shape will remain the same. So air fluid level will go in the same direction. Now, clinically, there will be more, there are three phases: acute, whenever there's more pus and less air; subacute, where will be less pus and more air; and chronic phase, there will be only air. That means it becomes a cavitary lesion. At the end, the abscess becomes cavitation, because with medication the pus will end. Okay, so that's what I was talking about, that in a lateral film and an AP film, this is frontal projection, we see this as a well circumscribed opacity within the right lung. This is the same as well. We have an air fluid level, that means the air is above the fluid will down because of the density. We can see this oval shaped lesion is similar to appearance in both the projections, with air fluid level in between. So they have a similar appearance on both, and that's typical of an abscess. Here we have this again, well circumscribed lesion. We can see thick walls are there, and there's air fluid level within it. Abscess will give the same appearance. They can be big. This whole lesion is an abscess, and we have a smaller internal air fluid level. Peripheral walls are thick, more of a pus, and a small air pocket within it. This is also abscess. This is like resolving abscess with cavitation. There can be turbid cavitation within the center or at the periphery. They may get communication with the airways and bronchial tree. And after 1 month follow-up, we can see this completely resolved after antibiotic therapy. TB doesn't go like this. Another pneumonia with the abscess formation, and then this was a pneumonic patch within the in the right upper lobe with the air bronchograms here we can see in a large air containing cavity. It cavitated over a period of time with multiple cavitations, air fluid levels within it, and on follow-up it was gone. So that was typical of infection. On CT, the abscess has thick walls and irregular surface. The enhancement enhanced with contrast. So whenever, as I said before, infection is a query, go for CT with contrast. They vary in size and rounded in shape, usually only fluid or have air fluid level. Initially, they have only fluid whenever there is pus. They can be surrounding consolidation with treatment that cavity will persist and then the consolidation resolves with the passage of time. So this is like abscess with cavity, air fluid containing cavity. And there's a consolidation with the periphery below, which will resolve once it will go. Okay, abscesses can be multiple. Whenever there are multiple abscesses with central necrosis, there will be a differential possibility because patients with the septic emboli, vaginal granulomatosis, and squamous cell carcinoma, they have various type of dirty cavity containing lesions, air fluid levels. So these are centrally necrotic fluid containing, debris containing lesions in both the lungs with surrounding areas of consolidation. So the history will tell how much it is like 6 weeks, less than 6 weeks acute or chronic, and how much the septic the patient is. So that's non-contrast and contrast enhancement, though that's a lung window CT, not very comparable to it. But when you give contrast, we can see there's no enhancement of the wall here. When you give contrast, they should enhance. It's a large cavity lesion with internal air fluid level. This fluid level should be very sharp. That's not solid thing, that's a fluid. So because there's some density difference between this one and the solid area. So there is a fluid level because the patient is lying down, the air is above, fluid low because of density, thick wall cavity with some ground glass change at the periphery. This is also abscess. I guess same patient, but there's contrast here. We can see that's esophagus. Forget about that. Patient may be aspirating because it's a bit dilated, and there's upper lobe thick wall cavity lesion with without any air fluid level. There's just air within this cavity. Maybe some septations over here and peripheral consolidation in this area. That's again abscess. That's typical of abscess again with some air pocket in it and fluid density surrounding consolidation. Uh, how? What are the differential possibilities? You have to differentiate it from other cavity lesions. Like I showed you previously, treated TB. Post primary TB has a different cavity pattern than this one. And from empyema, empyema is a fluid or pus collection between the two layers of the pleura. Okay, fungal infection. Fungal infection, they are broadly divided into two categories, human endemic, which are in certain geographical areas. They include three, histoplasmosis, coccidioidomycosis, blastomycosis, and opportunistic. They are worldwide distributed, and they more occur in immunocompromised patients, though immunocompetent hosts are also there, where they're not very evident. So therefore, Aspergillosis, candidiasis, cryptococcus, and mycomycosis. Aspergilloma and Aspergillosis remains the most commonest one out of these, I guess, and it has different pattern on imaging. There's a time countdown here on Zoom. I can't teach more than 5 minutes, I guess, so I will be rejoining after 2 minutes when it will stop. Okay, aspergillosis being the most commonest, frequent, and affecting most of the immunocompromised patients. So we will be discussing aspergillosis, but it is caused by infection ca- uh, it's a cause infection which is caused by a fungus called Aspergillus species fumigatus is the name, and it has different types which occur according to the immune status of the patients. If there's simply hypersensitivity, it is called ABPA, it's allergic bronchopulmonary aspergillosis. If the patient is normal, has a normal immune status, then it is called as aspergilloma, has a very typical appearance. If the immune status is mildly suppressed, then it's semi-invasive type, and if that person is very, very sick and immunocompromised fully, severely, then it's invasive form. The invasive form is the worst possible one. ABPA, it's exam film. People love to ask what is ABPA and how does it look like. It's a complex hypersensitivity type reaction because the patient has hypersensitivity already to aspergillus. So it occur in patients which are like having diseases, hypersensitivity disease, including asthma, cystic fibrosis. Now, what happens is the hypersensitivity will cause bronchospasm and bronchial edema, which is IgE mediated, that is occurring already in this patient because of hypersensitivity disease. So there will be bronchial wall damage, bronchiectasis, and pulmonary fibrosis. So patient will be having symptoms of allergy, asthma, and chest infections, or they will be having orange colored mucus plug.